I'm Sam Thompson, Program Manager at the US-UK Fulbright Commission. Thank you all for joining us for this public event in our Across the Pond webinar series, a new and exciting initiative of transatlantic conversations between Fulbright scholars. So far in the series, we've explored public engagement in science, and we've dived into how mathematics and engineering is helping to track the spread of COVID. It's great to have everyone taking a part in Across the Pond virtually. This is our newest webinar series, and we aim to connect our UK and US cohorts of scholars, along with you, our audience, together in these conversations. The series brings together two Fulbright scholars, one from the US and one from our UK cohort, to discuss the intersection of their interests. Here at the Commission, our vision is a world where there are no obstacles to learning, understanding, or collaboration. And this new series really brings that to life. We appreciate your participation in these conversations. Tonight, we'll take a look at another huge question for society: trauma. Trauma, be it physical or psychological, can be the result of violence, abuse, neglect, bereavement, warfare, or disaster, among other experiences. Traumatic events can leave a lasting impact on mental health and the ability to build and maintain relationships. Our two speakers see trauma regularly as practitioners in the field. What interventions exist to help people deal with traumas? How is trauma relevant to the understanding of current social or political issues in the US and the UK? How do we become more attuned to trauma in society? Our speakers will have much to say, and I'm looking forward to hearing with how we can all learn a little bit more about how this global challenge can be addressed in our day-to-day interactions with one another. But before I introduce our two speakers, just a little bit of housekeeping tonight. The session is being recorded. You will have seen the pop-up box when you entered, but just to let you know that it's being recorded and you can catch any of it later if there's things you want to go back to, or you have to drop out for any point throughout the recording, throughout the session. So please do check those out. And we also have our previous sessions online at some point soon, so you'll be able to check out those recordings too. We also, as I mentioned in that introduction, do want you to contribute to this. So if at any point you have a question that's relevant to the conversation being had, please do type it away in the Q&A box, and we'll get to that when we can. And with that, I'd like to introduce our speakers. Lucia Lee is a clinical lecturer of neurology at Imperial College London. She's a Fulbright all-disciplines scholar based at Massachusetts General Hospital, researching emotional function and how it may link with the dysfunction of the involuntary nervous system after a brain injury. And we're also joined by Heather Taussig, who is the professor at the University of Denver's Graduate School for Social Work and an adjunct professor at the Kemp Center for the Prevention and Treatment of Child Abuse and Neglect at the University of Colorado. Dr. Taussig is a Fulbright scholar at the University of Cardiff, and her research focuses on developing and testing prevention programming for maltreated children. It's a pleasure to be joined by both of you this evening. How's it going?
Thank you. We're excited to be here and continue the chat that we have started over the last, 6 weeks or so, preparing for this.
Yeah, it's a real pleasure to be here and share our work and our viewpoints, our different but complementary viewpoints with you all.
Yeah, great. So to get us kicked off this evening, what are the traumas that you both see in your own work, and what are the consequences of working with those traumatic experiences? If I ask Heather to answer first.
Thank you. We need direction. So I, as you said in your introduction, work primarily with young people who've experienced maltreatment, and that may be abuse, sexual, physical, emotional abuse, or neglect, and have had contact with the child welfare system here in the UK called Children's Social Care. And many of them have been removed from their homes and placed into foster care. And so while I by no means consider myself an expert in trauma per se, the young people that I work with regularly and develop prevention and intervention programming for have clearly experienced a lot of trauma. And the consequences are quite varied. And that's something that Lucia and I have talked about as well, is that you may have a similar experience that maybe on paper would read the same, and yet the impact it has on your functioning may differ greatly as a function of developmental stage, other factors related to your community, the response of loved ones around you, the color of your skin, clearly racism and structural inequalities that we see in both of our countries here play a role in adaptation following adversity. So while there are many negative consequences that are, or sequelae potentially of maltreatment, for example, substance use, delinquency, incarceration, mental health problems, as you talked about, Sam, suicidality. We want to be very careful not to stigmatize people or blame the victim as we think about consequences.
I think you raised an excellent point in talking about the breadth of consequences after injury. In my personal work, I see primarily patients who have experienced a traumatic brain injury in the moderate severe end of the scale. And a traumatic brain injury is defined as any kind of injury to the brain that results from an external force. So typically in the US and in the UK, the two or three biggest causes, unfortunately, are road traffic collisions, trauma, and assault. In the UK, we get fewer penetrating injuries than you see in the US, but those are sort of three top causes. What's very interesting and what I've always been very struck by, as Heather brings out, is that you can have the same kind of injury, but the impact on your day-to-day function can vary widely. Some of that is to do with the nature of the injury itself. So someone with a milder injury, for example, where they've not lost consciousness but been hit on the head or have not been admitted to hospital, there's no structural damage to the brain as seen by current MRI and CT methods. What you can see is that their previous way of life, previous personality factors, psychological factors interact with that injury and also interact with the environment that they then go into. So one of the, sort of anecdotally and also borne out in research, one of the things that really support good recovery after injury are pre-morbid, so pre-injury level of function, and also family and your social network that you have. In terms of consequences, I'm very struck by how deep, how far-reaching, and how devastating some of the consequences can be after a traumatic brain injury. Quite often in my clinic, we see people who, are in their sort of 30s and their 40s. So, they're at the peak of their career. They've got families, and after an injury, within sort of 12 months, 24 months, sometimes shorter than that, they've lost everything. They've lost their jobs. They've lost education. Their partners have left them, and often it's the sort of wife leaving them that's often also the trigger then for further things going wrong in their life, such as addiction. And the reason it's that way around is because certainly in the moderate severe end of the spectrum of head injury, it's we see a lot of young men. So if you look at the proportion or the demographics of people being injured, if you're under 40 and you're male, a head injury is the most likely thing to kill or cause you long-lasting morbidity. And then the other thing I'm really struck by is the link now between traumatic brain injury and neurodegeneration and mortality in general. So if you've had a brain injury over a sort of 20-year period, you are more likely to die of any cause. So whether that's a heart attack or cancer or brain-related things, than you are if you've never had that injury, and whether you've had an injury to another part of the body. So to echo what Heather has said, when we talk about trauma, whether it's physical or environmental, and I think Heather can speak to more of this, or psychological or childhood adversity, we shouldn't underestimate the extent and the pervasiveness of their consequences.
I suppose it's interesting thinking about that, in that both of you have highlighted, I suppose, almost a snowball effect or a domino effect, whereby if this goes unlooked at, it can lead to being involved in situations or environments where you gain further trauma, and you're then stuck on a road where perhaps a stronger intervention is needed. Is that a reasonable assessment of one of the things that you've said as a lasting consequence?
I mean, I think you hit on a really important point, and one that bears out, I think, in both of our work, which is that, there's kind of a cycle of trauma that both of us see, and that traumas, as we talked about, don't affect everybody in the same way. And that those people with maybe, pre-existing conditions or poor social, conditions prior to experiencing trauma are much less likely to experience what we might, call resilience. And so we do want to be tailoring our interventions based on, again, pre-existing factors as well as current functioning. But it's sort of incredibly unfair in that these traumas do affect people with fewer resources and in a more adverse way.
Yeah, absolutely. And sort of low socioeconomic status is a risk factor for trauma, for head injury. And it is also, head injury itself is a risk factor for, as you say, losing your job and losing family and all those kind of support networks that we need for quality of life, but also help people recover. And one thing that, I think this really feeds into is incarceration. And I don't know whether, you want to talk about that in your work, Heather, before I sort of jump in with my bits.
Well, no, I mean, I think now I have a horn going off. Sorry. Well, certainly, criminal involvement and incarceration are associated with experiencing maltreatment. In terms of, I wanted to maybe go back to the second part, I think, of Tom's question, maybe before we jump there, which is,
Sure.
Do we need to tailor treatments depending on, again, either the consequences observed or pre-existing conditions, I guess one might consider. And I do think there is a call for that and a need for that, and yet it's hard to know sometimes. I feel like both Lucia and my work, we don't know longitudinally how folks are going to do. So that's in part the importance of conducting longitudinal research to understand at what points in, again, development or post-trauma are people most ripe for what types of interventions. So certainly in my own work, we are thinking about for whom and at what time different types of interventions may be most efficacious, but it's also tricky to do that, right?
Yeah, absolutely. And as you say, with the longitudinal thing, if we're talking about the link between a traumatic brain injury suffered in your 20s or 30s and your risk of Alzheimer's down the road, I mean, it's fairly well accepted now, I think, in both neurological and neuroscientific circles that head injury is a risk factor for neurodegeneration. But what most projects are funded for 5, 6, 10 years if you're lucky, and actually you need decades. You need to come back to this population over and over again to see how they're doing before you really see how things pan out. And it's interesting when you talk about the sort of time to intervene. And one thing that's really interesting is pediatric trauma and the kind of way that a head injury in childhood can really impact physically on your brain. I mean, your brain is obviously developing hugely when you're a child and even into your late teens and early 20s. And it's the kind of the intersection between trauma. So if you have a head injury as your child, even if it did nothing to your brain, you'd be in, say you'd be in hospital, you'd miss some schooling, you'd then fall behind your peers. And then you have this question of, do you have to go back a year and how does that affect your social function and your friendship development? But also affects how you are able to engage in class. And we know that traumatic brain injury affects what we call executive function, and which is how you sort of plan and how you do things and organize your thoughts. It affects attention, affects concentration, all these things that children need in order to study. So you not only have this drop in function, but you set them off on a just, it's possible that the brain injury just sets them off on a completely different trajectory in the way that their schooling pans out. And I don't know what you think about, Heather, whether your research or your field has thoughts about when do you intervene, and is trauma worse when you're very little, or is trauma worse when you're a bit older? Because that's not known in about physical brain injury.
Right. I mean, I think a lot of researchers in my field would argue for early intervention. We all think early intervention, but the truth is, when you think about cycle of trauma, or trauma being a cycle, at any point in that cycle, it's worth intervening to potentially break the cycle of, again, what we see a lot of is violence and neglect, and the intersection, again, of poverty and racism and all of the things that make it very difficult for families to achieve healthy family functioning. And so it's sort of my belief that it's never too late to intervene, although, again, our interventions need to look different. One piece that I think is very different about our fields, Lucia, that we, again, had talked about a little bit, is that if young people are old enough when they've experienced the maltreatment and, again, placement in foster care, they have memories. And so hypervigilance and flashback are pieces of the trauma, sequelae from the experiences they've had. Whereas in head injuries, as you've talked about, they don't remember that. So while there's similar pathways, I think, to adversity or adverse outcomes, for example, dropping out of school because you can't concentrate or focus,
right.
The presentation of consequences of trauma looks a bit different.
For sure. And, I should say at this point, I'm not a child neurologist. So my knowledge of child brain injury really comes from my understanding of the research world, which there is, very little of at the moment, unfortunately. But you're absolutely right to bring out this idea of memory. So, when you have a very severe injury, and one of the ways that we define severity of injury is through how long this condition called PTA, or post-traumatic amnesia, lasts. And during this particular period, which seems to be quite unique to traumatic brain injury, is people are a little bit like, they can't lay down new memory. So you'll go up to this person and, you'll say, hey, how are you doing? And, you'll have a normal conversation with them. They'll remember who they are. They'll know who they are. They'll maybe know that they're in, they'll probably know they're in hospital, and, you might have to remind them. And you have what seems like a really normal conversation. You go back and, you leave and you come back maybe the next day, or even sort of 6 or 7 hours later, and they'll have no memory of who you are or what you've talked about. So this period of post-traumatic amnesia, in some ways, it defines how bad their head injury has been. How bad is their brain being shook by this impact? But what I've always been struck by is, I see people in my clinic who've had some horrific injuries, from car trauma or from, assault and that kind of thing. And I'm struck by how little sort of PTSD there is, by the sort of psychiatric definition. And maybe there's something, we've discussed this in our clinic, and people haven't tested this theory, and I think it would be interesting to test, but is there something about this loss of memory formation in their early days after trauma that somehow protects them? That's not to say people don't get flashbacks and don't have memory, but the kind of flashbacks they get are often related to the bit after the injury. So they don't necessarily remember the impact. They'll often say, the last thing I remember is seeing the car. The last thing I remember is I was cycling down the road, 10 minutes maybe from where they were injured. And then they'll remember sort of bits about ITU. They'll remember bits about their early recovery. But yeah, it's something about that protective bit. Maybe it's protective, that means they don't get PTSD. This is obviously not true for certain things such as war. Military veterans, unfortunately, are a group of people who experience a lot of PTSD, and that's much more that's likely related to the fact that a lot of the head injuries that we're seeing in that is what we call blast injury, which is where, because of the improvised explosive devices that are now characterizing the theaters of war in the Middle East, they maybe don't get the classical head injury that knocks them unconscious for hours and days. They may be getting a particular type of pathology called blast injury, but also they're exposed to all sorts of other violence, which they do, unfortunately, remember very vividly. And I wonder if that same sort of thing applies to the childhood and environmental traumas that you see.
It's very hard to know what pieces are, the most traumatic, for example. And we talk about complex trauma for young people that have experienced more chronic adversity. It may be that you show up to school one day in clothes that are maybe not appropriate for the weather, and you are bullied or teased, and that may be more of having a more adverse impact, because at certain developmental stages, peer acceptance is so critical. We also know that witnessing community violence is very strong predictor of adverse mental health and other kinds of outcomes, even over and above having like experienced physical abuse in your own home. So again, it's difficult to know for whom different traumatic experiences may affect in different ways. What we've tried to focus on in the work that I do is, again, how do we think about addressing traumas, treating trauma, and preventing some of the associated adverse outcomes. And so we don't get a lot of children that that qualify on a diagnostic scale for classic PTSD, although they will identify, trauma symptoms that they have, and they look very different. What we have done is focus on positive youth development. And there are very effective treatments out there that focus specifically on trauma for young people and for adults that can be very effective. But because of the heterogeneous effects of trauma for young people, we have focused more on empowering young people to engage in healthy behaviors and learn healthy skills for emotion regulation, which again, Lucia and I have talked about is a consequence of both of the traumas we see, and healthy communication skills, problem solving, and also trying to reduce stigma that's so often associated with having experienced abuse and neglect or being placed in out of home care. So our program is really, and it's demonstrated a similar reduction in scope of trauma symptoms to other more trauma-focused programs. So it's very interesting that a more positive youth development program, which focuses on building skills, engaging children in activities, in the program that I direct, Fostering Healthy Futures, we pair them with mentors who, again, are helping them practice these important social skills in the real world and introducing them to activities that build on their strengths and interests. So, we hope that we're continually developing new and innovative ways to address trauma, because it won't be one size fits all.
Absolutely. And it's really interesting to hear you talk about stigma, because in some ways, stigma exists because there is recognition of a problem in some ways. And I feel that traumatic brain injury, and again, I talk mainly from my own clinical experience working with adults with severe traumatic brain injury, is there is both over and under stigmatization, if that makes sense. So if you had a heart attack, you would go into a hospital, you would be seen by a cardiologist, a cardiac nurse would look after you. And then when you leave hospital, you would have this beautiful plan drawn up for you about, your medications, and you're going to come back and see me in 6 weeks for your repeat scan, and you're going to have specialist cardiac rehab. You get none of that if you have a traumatic brain injury. I have seen patients in hospital who are admitted under all sorts of sort of quite random specialties. Not that they're not good at looking after them, but they're just not specialists. So I've seen people looked after by orthopedic surgeons because they happen to have also broken their arm. And, a neurologist doesn't get involved sometimes ever, and sometimes not until very late. And, you've got this poor person who has quite clearly got neurological derangements that is just not being recognized and not being therefore treated. So that's kind of almost the under stigmatizations that certainly, I feel in the UK, we don't have a recognized pathway for people who have traumatic brain injury, which blows my mind, because more people are admitted to hospital every day with a traumatic brain injury than have a heart attack and are admitted. And yet the pathway exists for heart attacks and does not for traumatic brain injury. And then so that's kind of the under stigmatization, the under recognition of the impact to which trauma can have and a traumatic brain injury can have even years down the line. And we saw this, when the professor of the lab that I work for, David Sharp, opened his TBI clinic, specialist TBI clinic in West London. I think it was about over 10 years now. We suddenly had this influx from GPs and family practitioners who were like, oh, thank God, we finally got this clinic. And, there are these patients 20 years after their injury who are still having problems and no one's kind of looking after them. But then there's also the over stigmatization, which is, oh, well, everything to do with your trauma. And I think this happens a lot also with milder traumatic brain injury. So, maybe also in the sporting arena where everything is assumed to be the trauma. Oh, you're sort of, you're still not recovering. You're still not sort of kind of back to work at sort of a year, that's just a trauma, you'll get there. But then no one digs into why that's the case, right? As you say, people get to a certain level of function from a lot of different reasons. And actually what we find is, as you say, it's never too late to intervene, first of all. And small things that can change someone's quality of life can have a huge impact on their function. And the real typical one for us is sleep and headaches. So post-traumatic disruption of sleep and post-traumatic headaches are a big problem. And that's becoming more recognized, to be fair. But it is still quite under-recognized. And we'll have people saying, oh, I'm still not back to work. And you dig into it and you dig into it. And, why are you not back at work? Oh, well, my migraines are so bad that I'm in pain and I just don't feel it. And I just feel tired all the time. Oh, why do you feel tired all the time? And it finds out that, they've not had a sleep routine and no one's looked into this, and some simple advice and, a few simple medications can treat their migraines, can treat their sleep. And that, maybe that's all that's needed to get them to go back to part-time work for a start. And then that sort of, just like you can have a vicious cycle, you can also have a virtuous cycle. And I often say to my patients, they always laugh at me when I say this. I say, when your brain is injured, you need three things. You need good sleep, you need exercise, and you need a little bit of social and cognitive sort of interaction. And if any of this sort of goes away, which it can do very quickly, because if you have an injury and you're not engaging at work, you maybe lose your friends at work, and you get this sort of spiral of isolation. If you can reverse any of that, you often do better.
I think since you've both spoken a little bit about the work that you do directly with people, it might be good to move to our first question that we've had from the chat, because I think it's really relevant to what you're saying and makes a nice, an interesting insight, or perhaps you could provide an interesting insight on what they've asked, which is often when we work with those who have experienced trauma, we talk about compassion fatigue and secondary trauma. And how do you as practitioners deal with both in terms of your own well-being, but also so that it doesn't impact the quality of your work with those who would benefit from your work?
Yeah, I think that's a great question. And we think about it a lot of time, not just for our own selves, those of us who are running, let's say, our program, Fostering Healthy Futures, but the mentors who we bring in. Self-care obviously is very important. And, unfortunately, you do habituate over time to hearing pretty horrific stories about things that have happened to young people. At the same time, I get asked all the time, how can you work in child abuse and neglect day in and day out and not feel depressed, overwhelmed, hopeless, all of those kinds of things? And I chose a path, I think, though, that is very positive. So, an overused term is resilience, but that's what we're shooting for. And the other piece is that I've been working with this population since I was a teenager. And what's always struck me is that while you can look at the statistics on one hand and see really, high rates of, again, adverse outcomes among this population, there's a huge chunk of people who don't go on to experience adversity long-term, or don't continue the cycle. So I know we started there because we talked about the consequences. But what is super intellectually stimulating for me and then the people I work with is, again, how do we intervene to bring about positive outcomes? So the work that we do is really very powerful, empowering. It's very, it leads to a lot of satisfaction in our program by our clients and our program participants. So I think that's one of the ways that helps me personally and our team not get burnt out in secondary trauma.
Yeah, I think that's a very good point. I imagine secondary trauma is probably more of a risk for you, Heather, than it is for me, simply because, I hear the horrific stories, but thankfully, because I don't work really at the acute end of the spectrum, the ITU physicians, the A&E doctors, the neurosurgeons, they're really dealing with the sharp end of the patients that I see, because they're coming in, straight from the side of the road, straight from, being assaulted. And thankfully, I don't get that sort of visceral exposure. I hear the secondhand stories, and, I do sometimes after a hard clinic where, I've heard 2 or 3 patients who've just gone through a lot, and, they're maybe 12 months after their injury and things aren't getting better, or they're 3 years after their injury and things have sort of fallen off the wayside again. You do get a bit sort of, oh God, how are we going to fix this? How are we going to fix this? And I think that's where the research side comes in. And I think being a clinical academic, we are very privileged to be able to turn some of that frustration at there not being a solution into our research to try and find a solution. I mean, the program that I'm working on at the moment, this looking at emotional dysfunction after traumatic brain injury, the reason I'm doing this is because I've had, to put it frankly, I'm sick of having nothing better to offer my patients than my sympathy and some medication. I feel like that we must be able to find out more. There must be more that we can do and understand. And part of that is the research, and part of that is advocacy as well. I would say advocacy is something I would like to improve in and get better at, because I think our patients do not have enough, a strong enough voice for them. There's a Welsh MP actually who Chris, I've forgotten his last name, this is very embarrassing, but he's an MP for Rhondda, and he has started an all-party parliamentary group looking at traumatic brain injury. And I think we need more figures like that to push the agenda forward. So, that's something I'd like to work more in, to try and change the way healthcare is delivered for people with traumatic brain injury. And I think that's what you sort of try and do when things look like they're never going to get better. You sort of try and see the bigger picture and work at the things that you can work at. But sometimes we get good stories.
Sorry, I was going to say, I think that's a really nice segue back to where I think you were headed before, in talking about incarceration. So, yeah. Love for you to share your thoughts on that relative to TBI, and it relates to, again, experience of maltreatment and ending up incarcerated.
So I would say the incarceration is, I guess, perhaps an extreme example of the relationship between traumatic brain injury and neglected populations in general. So there's work done by one of our collaborators, Tom McMillan, up in Scotland, who has looked at the prevalence of traumatic brain injury in prison populations in Scotland. There is a Professor Hugh Williams, who again is Welsh, but I think he's currently in Essex, who has worked very hard at looking at traumatic brain injury populations in England. And the incarcerated population has a really, really high prevalence of traumatic brain injury, both before they ever commit a crime. So basically this is kind of lifespan experience for traumatic brain injury. But then of course they get into prison and accrue further traumatic brain injuries. And these sometimes are a single bad hit, if you like, that ends up being in hospital. Or these could be several sort of milder, but they're accruing at a particular time in their childhood when their brain and executive and social function is developing. And what does that say about how they develop? But also it's repeated. But this also is the case for domestic violence, so intimate partner violence, and also in homeless populations. So we're talking upwards of 70% of, in each of these populations who have suffered a traumatic brain injury at least once in their life. And these are huge numbers. And you think, well, I'm not being an apologist for crime. I'm not saying you've had a traumatic brain injury and therefore you shouldn't have consequences associated with that. But if we look at the consequences of that, so traumatic brain injury is associated with increased recidivism after crime in incarcerated populations. So, by intervening and providing rehabilitation, you're not only doing the sort of moral and compassionate thing, you're also doing something that will benefit society at large by preventing repeated crime. And by rehabilitating, you're preventing people from, you're giving people choices of other things to do besides getting back into those environments where they may suffer more traumatic brain injury and more crime. And the same goes for, intimate partner violence, and the same goes for homeless. These are cycles that we need to address. Otherwise, we're forever being reactive to their consequences.
And one way I think we as a society are starting to talk about addressing this is in taking either a trauma lens or what we call trauma-informed care. Right. the social problems. And so what we're going from is stating what's wrong with this person to what happened to this person, and how can we understand their behaviors in the context of physical or psychological, emotional traumas they may have endured. And that relates to the movement to defund the police, and it relates to decarceration that we're talking about here, and trying to understand, again, how the impact of trauma has led to behaviors, and then the response from the community or professionals has been such to exacerbate actually problematic outcomes as opposed to ameliorate the trauma.
And what do you feel in sort of your line of work? Obviously, you work with children where it happens very early, at a very crucial stage. How does the trauma lens work? Because they come across a lot of professions in their lives. You know, we're talking teacher, talking education. Do you feel that that is a helpful approach, or does it also have its drawbacks?
So I think there are two ways I'd answer that question. The simple one is that, you know, obviously if they're seeing mental health professionals, they're well aware of consequences of trauma. So educating teachers to have more trauma-informed approaches in their teaching, and to understand where, again, the etiology of some kids' problematic behaviors in the classroom is really important. Also, for children like that we work with who've missed enormous amounts of school or have changed schools 10 times by the time they're 10 years old,
right?
That any kinds of learning challenges that they may have experienced often don't get picked up. So, I mean, there's educating folks, one, about trauma and the consequences, and also about, you know, a child welfare involved population who may have experienced extreme instability in living situation and then schooling as well. So I think that can be very helpful, but it has to come with what do I do? How do I practice?
Right.
This? And again, identifying young people's triggers for escalation is one way. What sets them off? What is making them re-experience potentially other traumas? Understanding why they might not trust that you're going to be a safe person and a consistent person in their lives, and hanging in there through some of this, and offering compassionate care as opposed to punitive approaches that may just reinforce that adults, for example, are unsafe. At the same time, there's a lot of research on ACEs. And so I don't know if our audience has heard about adverse childhood experiences. And again, a lot of research and recent press has come out about the linear relationship between the number of adverse childhood experiences we've had, and again, adverse adult outcomes, both physical health, mental health, again, substance use, etc. So in California, for example, they started screening for ACEs. And the question there, and some of the controversy is, great, so now you've screened for ACEs and you understand somebody scores, you know, a 9 out of 11, whatever.
Now, you know, what?
Now what? And do we have appropriate referral sources for people who've experienced ACEs? And again, are we just stigmatizing people and saying that you are at risk for a host of adverse outcomes based on your score on this ACEs measure? And lo and behold, we don't have anything to refer you to, nor do we know that these adverse things will happen to you. You just have a higher risk. So we have to be very, very careful when we think about, you know, implementing trauma-informed approaches or screening really more for trauma. But I don't think it's can be a bad thing to understand, for our communities to understand how trauma can have adverse impacts and how those can cascade in the ways we've talked about.
Yeah, I think this goes back to a little bit about identifying. And identifying can be good if you can do something about it, and if there's a really clear idea of, excuse me, how you're going to, you know, deal with the problems that might arise, and how you're going to nurture this person and rehabilitate this person and integrate them. But you're absolutely right, and a lot of therapy, or some of the therapy that we refer our patients to, is vocational rehabilitation. So how do you get these people back into work? And some of the vocational therapists talk to me and say, actually, what we find, some of it is educating the employer and saying, this person's had a head injury, they are going to have trouble concentrating, blah, blah, blah. But, you know, you don't have to like redraw the whole company for them. You just have to do simple things. For example, schedule a meeting, not for 1 hour blocks, schedule them for 20-minute blocks. Simple things like that. Make sure that they've got time to write things down. And it's not even big adjustments. It's not sort of, oh, they have to work less. It might be they have to work flexibly. You know, they're quite happy to work your 40 hours, but you just need to give them a little wiggle room about when they do those hours, because, you know, early mornings might become harder for them. So some of it is, you know, goes back to the whole advocacy thing again. And you were talking earlier about, you know, what happens when a teacher identifies these things and knows what the triggers are. And I think one thing this relates to one of the questions that was asked earlier, which is the sort of, you know, observer compassion fatigue and secondary trauma. There is a hell of a lot of secondary trauma on families and, you know, the observers of a traumatized person. So the class example from the work I do is the family. And there's this great book called, I think, I want to say Crossing the Void or something like that. It's by James Cracknell and his then wife, Beverly. And he was an Olympic rower who had a really horrific traumatic brain injury whilst cycling. And it's a pretty, you know, all warts exposed account of what happened really to their relationship after he has his injury. And one of the saddest things that I always find is the breakdown of relationships after a severe traumatic brain injury. And part of that is that, you know, people who have traumatic brain injury, one thing that can happen and does often happen is immense irritability, emotional lability, which is where people get, you know, a 5 1 minute and the next minute they can switch, anger. And that's the kind of thing that I want to work on now, because I can see how devastating it can be. And it's not for one to try. You know, there's a lot of motivation both from the person who's been injured and their family, and you know, there's the attention is always there to try, but it's just really, really hard. And it's, you know, it's hard being that brain injury person, but it's also really hard to be the partner of someone who has got brain injury and, you know, is suffering these symptoms. And at the same time, it's sort of not stigmatizing. It's not saying to them, look, you know, this is going to happen and it's going to be awful. And, you know, frankly, you may as well, you know, hire divorce lawyers now kind of thing. It's about, these are the things, you know, where you're at risk. We would recommend, therefore, that we start doing this kind of thing, and we start doing it early, and we start educating earlier. We also start putting in interventions early, frankly. And I think there's, you know, there's got to be more support for carers. And I work with a charity called Headway West London. And the carers group is the one thing that over again and again, we hear that people really value. It's a place for people to have peer support. And I'm sure this comes up in your work, because, you know, if you're a teacher and actually you're not a clinician, but you're a teacher, so you're not seeing the day-to-day, but you're seeing, you know, maybe 2 or 3, you know, pupils in your class. I think it can be quite difficult for them as well, and knowing how to handle it, and also always maybe worrying that they're doing the wrong thing, because we get that from our patients' families. You know, people are always worrying that they're doing the wrong thing, or how can I best support my family? And it's very hard, and it's often difficult to know where to go, especially because there aren't that many services for my patients.
We've had a number of questions throughout the chat, so I might move on to those, and some of those are related actually to that last point. So I might start there in terms of when you're talking about teaching, especially. So one of our audience members is an educator who's doing research connected with emotional trauma for non-majority students, and they're interested in any involvement that either of you may have had with schools, and how they have or perhaps haven't responded to students who have had any of these experiences that you've talked about today.
I mean, it's so variable. And so you said minoritized students, is that what?
Yeah, the wording they use is non-majority students.
Non-majority students. And so, you know, there are lots of things that make young people non-majority. If you identify LGBTQ, if you, again, are of a racial or ethnic minority, if you've experienced trauma. I think it depends. I'm going to focus on when that may affect a young person's functioning. And so, teachers are very different and schools are very different. And we've had teachers for young people that we work with that have really been their, sort of savior. I mean, we have followed young people from ages 9 to 11 into young adulthood. And we asked them in young adulthood, who was one person who was really there for you while growing up? And sometimes they identify a teacher. Also, in the development of our Fostering Healthy Futures program, it's a 9-month mentoring program. And we worried about having a 9-month, a time-limited mentoring program for children who'd experienced a lot of loss, right? Children in foster care who changed placements. So we ran focus groups or discussion groups before developing the program and talked about, would we need to find mentors who would stick with kids for, their whole childhood and into adolescence and young adulthood. And many of the young people identified a teacher from many years ago, potentially, who was only with them for 9 months, but who had such a profound effect on them in a positive way, obviously, because they believed in them, they identified strengths in that young person, they gave them hope for the future, they were a safe place to go to. Maybe they reduced bullying that was happening in the classroom. So teachers can play a very critical role, I think, in fostering healthy outcomes for young people who are minoritized. And I think sometimes teachers maybe worry about identifying some of those differences among young people, but just, being there and being a support for them and being an open ear can be a huge source of support.
Great, thank you. And then I think one that both of you might have some interesting answers for, which is what place do you think that the arts, music, literature, creativity, and so on might have in developing either resilience or the healing process for trauma?
Well, I won't say much on this because I'm not an expert in this either. I don't want to speak outside my expertise. However, for stroke, for example, and for people living with dementia, arts therapy and music therapy, kind of engaging their brain again, doing something which creates a lot of interest and motivation for them to engage, and also which, for example, with arts or playing a musical instrument really, gets them to move an injured limb, is very much part of therapy and rehabilitation. And actually, if we think about apathy and demotivation as actually being a neurological consequence of traumatic brain injury, I think introducing those things as a natural and joyful way to motivate people to engage with therapy is excellent. And I'm all for it. It's just the funding for it is also always a little bit less than one would wish.
And I'll piggyback on that to share that these activities can be wonderful for children. Again, that's the mentor's role in our program, is to identify what children are interested in and build, again, on their strengths and interests and set them up with extracurricular activities. But this gives me such a lovely opportunity to do a shout out to my host institution here in Cardiff, Cascade, at Cardiff University, because there is a researcher here, Dawn Manet, who has done art activities, drama, and other kinds of experiential activities with young people in foster care. So there's actually research and work going on right now about that for, again, the population with which I and Cascade works with. So thanks for that opportunity.
That's really great. So I'm going to ask these in a slightly different order than they came in for, because I think one of these is a really nice concluding question, perhaps, if we don't get any others as we move towards the end. We're in about the last 10 minutes or so here. So the next question that I have is, have either of you studied intergenerational trauma, particularly looking at the children of survivors of trauma?
So I haven't, I would not say I'm an expert in that in any way, but we do see cycle of of maltreatment and foster care in the populations with which we work. And so we ask the young people in our study about their parents. Their parents also report on their own histories. And so that is something we observe and does come out in our work, but I couldn't say that I'm an expert in that. There's also, a historical trauma, and that's a piece of this multi-generational piece too. That doesn't just relate to maltreatment, but again, in the US, our treatment of American Indians has led to generational and historical trauma, and slavery in the US and current racism that is so pervasive has really led to, these populations continually being traumatized, marginalized, and the consequences being repeated.
I mean, I'm not a social scientist, so I'll speak to the biology of this, but the impact of trauma has the capacity to modify the expression of your genes. And this is something called epigenetics. So if you imagine your DNA as being something that's written in ink, so that's the book that's written in ink. So you can't rub that out, you can't edit it. But the expression, so which parts of that book get read out, which parts of that book forms your biology in your life, that is editable. And that's kind of, if you like, the pencil markings, the annotations you might make in a book that's printed in ink. And that is modified by our environment and our experiences. So, if you look at just single generation, so there are animal studies showing that pregnant mice who experience trauma, head injury, I'm talking about head injury, not a, environmental trauma, but a head injury, their young have different brain, the brain structure of their baby mice are different to those who have not experienced trauma. If you look at humans, I mean, this is difficult to entirely disentangle from sort of environmental factors, but women who have had poor diets, women who, we're very comfortable with the idea that a pregnant woman, must be protected from things like toxins and alcohol and smoking and bad environment. But and why do we think that is? It's because it affects the biology of their young, i.e. their human baby. And part of that, part of that is literally just from a single generation to the next generation. But as opposed to multi-generation, I think it is this epigenetics, this kind of editing of the expression of your genome, where this may come in. So there is a biological basis for trauma or physical trauma, and I can only speak to physical trauma of one generation impacting the biology of future generations. And I can imagine that intersects with what is going on environmentally and socially.
Certainly, and I suppose, as we talked about earlier, this idea that you enter a cycle. So if you are inheriting, I suppose, physical trauma as part of that cycle, you are potentially put on the start of that cycle, even if you were in an environment that was otherwise insulated, perhaps, or protecting you against that cycle. And so it potentially then causes that intersection that you're talking about.
Yeah, I mean, potentially, but I think Heather and I always say this at the end of our conversation. God, it sounds all really depressing, and but not at all. I think first of all, the work that Heather is doing in building resilience in young people, she's rewriting potentially the trajectory of someone's life, and that's great, right? That's the whole point. You're intervening then. And I think that's also the thing with my patients. Obviously, they have ICU patients who are adults who are injured, but the work is hard, and it's not that it's easy to do. But the point is, if we identify people who have had traumatic brain injuries, if we offer them the services and the rehabilitation that they need, and dare I say it, if we are able to erase some of the structural inequalities, or even just the sort of problematic social structures that they then enter into after their injury, such as social isolation, losing their job from unsympathetic employers, etc. If we can work on that, the outcome doesn't always have to be terrible. I see plenty of cases in my clinic where people have had horrific injuries, and I look at their scan and I look at the patient sitting up and be like, but, and it turns out that obviously they're potentially often quite lucky. They maybe are young, previously very fit, they've got good jobs, they've got a sympathetic employer, they've taken 2 or 3 months off and it's been okay to do that, and they've recovered well. We do get success stories. I sometimes say I've got very little to do with them. I just sort of support them whilst their brain repairs itself. But we do get success stories. But the point is, we need to, we being the medical profession, the rehabilitation profession, the social environment, we need to support this happening. But if we are able to do that, then we prevent the personal and societal consequences of trauma, but we also restore the lives of these people who've experienced trauma. So it's a very worthy goal, I think, and worth the investment.
And I think we don't, there's a huge focus on evidence-based practice, and that is absolutely critical. And as the director of a program that has been named evidence-based, I'm very proud of that. And yet I think we need many more contextually sensitive interventions that take people working on the front lines to come up with a creative solution. Because Lucia, I love that you gave this example of maybe you do meetings for 20 minutes instead of 1 hour, and maybe you allow them time to write something. Small things can make a huge difference, and we don't know what those small interventions might be. And so I would encourage our listeners and others to continue to be creative in developing strategies to ameliorate the adverse consequences of trauma, and to, again, really foster positive development following the experience of trauma. Because I think those on the front line are best equipped to think about innovative ways. And those of us in academia are then here to test that and see if it's effective. And so, academic practice partnerships are very fruitful. And as you said, Lucia, I think it's not deterministic, any of this. And that's what our work is about.
And I'm very inspired by the work that's, so like I said, I'm a neurologist, so I work in sort of more the chronic side. But the acute side, there are some surgeons and intensivists and A&E doctors and trauma doctors who've done really good, well-funded, large-scale studies in this area. And as a result of policy interventions, things such as seatbelts and cycle helmets and that kind of thing, and different ways of doing surgery and different, interventions early on, and the changes in practice in trauma care, the acute mortality from head injury has gone down over the years. So what we've got is, we know research works, we know intervention works, we just have to have, the courage backed by the funding and the people and the interest to do it. So let's see if we can take some of those gains in acute survival and change that into better lives afterwards.
And with that sense of looking forward, and I suppose also bringing us back to our original reason for being here, which is that transatlantic nature of what you're both doing, what do you think is being done right in your host institution that your home, or your host country even, that your home can learn from, or your practice at home can take back and integrate into their own best practices?
Well, what I've been struck with here, I'm in Wales, so it's a relatively small country compared to the United States, so it's hard to sort of make comparisons. But the way that my colleagues here approach problems does seem to me to be a little bit different than how we often approach things in the US. And it does in part relate to evidence-based practice. So if we were to run what's called a randomized controlled trial in the US and find no statistically significant differences in outcomes for the control group and intervention group, we're typically moving on to the next thing. Whereas here, there's a lot more qualitative data collection. So who liked it? Why did they like it? What parts did they think were effective? As well as what they call a realist approach here, which is what worked for whom and under what conditions. And so I've been very impressed by the thoughtfulness of approaching intervention work here, and as well as the creative approaches to addressing seemingly intractable problems.
For my part, I've always been very impressed by the American sense of optimism. I think as someone who is on the more kind of Eeyore/cynical side of the end of the spectrum, I think that this sense of verve and yeah, of course we'll get this done. That's no problem. We'll do it. Yeah, let's do it. I love that, and I think obviously MGH is a very special place, and shout out to my host lab, which is the Coma Recovery Lab run by Brian Edlow. The sense that what you do makes a difference and makes a difference to the patient, and therefore there's that real motivation there. I think sometimes you can lose sight of that a little bit because maybe we're not over, I think we're appropriately sort of measured and critical in the UK of our results and our of our science as well, but just that sense of here's an opportunity, let's create the opportunity if there isn't one already, and let's just do it. Just JFDI. And I think we could maybe I could definitely do with a bit more of that, and I'll try and imbue my future UK colleagues with more of that as well. Although my UK colleagues, but maybe it's just me that needs to have more of that. But
I think that's
American sense of optimism.
That's a really lovely note to end on, as we have slightly exceeded our hour together here, but that was really fascinating. I feel like we could have probably gotten another hour in at least with some of the avenues that we opened here today. Thank you both of you for joining us. It's been a real pleasure, and thank you everyone at home for joining us too. And if you had to miss any of it, as I said before, we'll have recordings up as soon as we can for you to go back and watch. If you're really interested in what we're doing and you want to get more conversations like these, we've got next week coming up a conversation on storytelling communities and cultural institutions. You can go on our website, fulbright.org.uk, to sign up for that now. And then we're going to take a short break of a week before we head into August with a whole new host of conversation topics for you to come along and listen to. We also have coming up in terms of applications, if you're interested in what we do here at the US UK Fulbright Commission, we have our Civic Science Storytelling Award is open, and if this is something that you think appeals to you or is something that someone in your network might be well placed to do, we really encourage you to either apply or share this as widely as you can. We think it's a really incredible award and a great opportunity. So those are just a couple of end matter notes from me. But other than that, thank you again for taking the time to come and listen to Heather and Lucia today, and have a great week, everyone. Goodbye.